Good morning, everyone. I call to order today's hearing of the Public Health and Developmental Services Committee of the second extraordinary session. Today we have an informational hearing entitled Supporting and Enhancing California's Medi-Cal and Developmental Services Programs. And just want to thank you all for being here. Welcome to this first hearing of this policy committee in the second extraordinary session. I want to express the committee's appreciation and my personal appreciation to all of those who have agreed to be witnesses today. Thank you. This committee is embarking on important work. As you all know, in the wake of the enactment of the 2015-2016 state budget, Governor Brown called for 2 special sessions of the legislature. The second special session is devoted to matters pertaining to Medi-Cal and services for the developmentally disabled. This committee, the Public Health and Developmental Services Committee, will be the policy committee for the second special session. As the one policy committee for the breadth of that session's issues, the jurisdiction of the committee is very broad. As a result, this hearing is being set up as an introductory and educational session. There will not be any public comment or public testimony taken at this first hearing. I want to repeat that. At this hearing, there will be no public comment or public testimony. We want to save public testimony for our next 2 hearings. We have currently planned 4 different hearings. This is just the first one. It's informational and educational, as I mentioned. We'll have 2 additional informational hearings during the week of August 17th. One will focus specifically on the Medi-Cal program and the other on developmental services. These hearings will have stakeholder witnesses and ample time for public comment. I want to emphasize that we do want to hear from the public. We do want to hear from the public. We will always take written testimony. We also have cards to be filled out today for people wanting to testify at our August hearings. I want to say again that we do want to hear from the public and stakeholders. After the informational hearings, the committee will be ready to hold bill hearings to consider special session legislation. The special session is an opportunity for the legislature and governor to address some important issues that we could not resolve in this year's budget, in particular the possibility of rate increases for providers of Medi-Cal and developmental disability services. Critical to our work is the reauthorization of the Managed Care Organization tax, or the MCO tax. The MCO tax is an important existing source of funding for the Medi-Cal program. The administration estimates it will offset general fund spending for Medi-Cal by over $1 billion. If that tax cannot be reauthorized, we are looking at trying to fill a significant hole in the Medi-Cal budget next year. If that hole emerges, it will be extremely difficult to address rate increases or other program enhancements. I know the witnesses will go into this issue more, but reauthorization has become much more complicated this year than in past years because of the directive from the federal government to make drastic changes in the form and structure of the MCO tax. We'll have more discussion on that later. At this time, I want to open it up for any members who'd like to make any initial remarks. Assemblymember Thurmond.
For the opportunity for us to work together in this extraordinary session. We obviously have extraordinary challenges, but I believe that our work together can help us find a pathway to victory for people who need our support. Clearly, those who are served in the developmental disability community have experienced tremendous cuts over many, many years, and in spite of providing great service, have not been able to have any funding levels restored. And so it's exciting to have an opportunity to help identify a path for how to do that work. Similarly, we know that millions of Californians are impacted by lack of health care access, and in part due to Medi-Cal reimbursement rates, and that California lags many other states, and that we have a tremendous opportunity to do something to support the great health and welfare of those who depend on us here in the state of California. And so I'm looking forward to working with you, Mr. Chair, and to all the members of this committee and to all the stakeholders to find solutions to help us move towards the aforementioned goals.
Thank you, Assemblymember Thurmond. Assemblymember Levine.
Thank you, Chairman Bonta. California is in a public health crisis. We must take action, and we must do it now. We need a reliable source of funding for our state's most essential services, including Medi-Cal, developmental services, in-home supportive services, and basic health needs. If we don't do something, we will face a $1.1 billion drain to the general fund. This means reduced funding for health care, higher education, transportation, and other critical programs. Doing nothing is simply not an option. We must find a reliable source of funding to continue the restoration of IHSS, increase Medi-Cal reimbursement rates, and better fund critical developmental services. These are people in need, and they deserve much more than we are giving right now. By adequately funding these services, we also reduce overall health costs for all Californians. By getting people out of emergency rooms and urgent care, and we lower costs and improve the quality of life for everyone. I look forward to working with my colleagues in this extraordinary session to address this pressing issue. And then on a personal note, I just saw a Cal State Northridge sweatshirt back there. Go Matadors. Thanks for being here today.
Thank you, Assemblymember Levine. Assemblymember Stone.
Thank you, Mr. Chair. I know there's been a great deal of frustration that these fiscal issues were not worked out in the budget. But I guess I'm an optimist, and I see this special session as an opportunity to address the issues in a much deeper way and a much more permanent way. I think that is our obligation here. Because with the Medi-Cal cuts and the developmental services issues, those are really funding issues that we need to be paying attention to. And as we're significantly changing over the next few years how developmental services are delivered in California, more on a community-based basis, in a much more hopefully humane and appropriate way, it will take an investment from California in those services in order to deliver them appropriately and correctly. The obligation, the rights of the Lanham Act are still there. Even as we change how developmental services are delivered, it is our obligation to make sure that those rights are unaffected, and we cannot do that without adequate funding streams, permanent, ongoing, so that we're not fighting this every single year in the budget process. If you have questions about the Lanham Act, Santee Rogers has a copy of it in his pocket that I know he carries around with him all the time. He'll be testifying later on today. That's our opportunity. That's our obligation to look at in this special session. And I know that frustration has been there, that we hadn't dealt with it along the way, but I look forward to the public testimony, to the broad involvement of the communities, and solving this problem on an ongoing basis and having appropriate funding for Californians who need us the most.
Thank you, members. We're going to go to our first panel. I want to invite the presenters of our first panel on developmental services. Providing an overview, we have Sean Martin, Managing Principal Analyst, Health and Human Services, Legislative Analyst Office. Mike Wilkening, Undersecretary, Health and Human Services Agency. Santee Rogers, Director. John Doyle, Chief Deputy Director. Nancy Bargman, Deputy Director, Community Services Division, Department of Developmental Services. Welcome, and thank you for being here. Whenever you're ready.
Thank you. Sean Martin with the Legislative Analyst Office. I've been asked to give an overview of the developmental services. I'll be speaking from a handout. Everyone should have a copy of it. So if you look at page 1 in your handout, it gives an overview of the presentation. I'm going to go over the background on the Department of Developmental Services. I'm going to talk about rate structure in the regional center system. Then we'll talk about major DDS budget solutions affecting the Community Services Program from 2003-2004 to 2015-16, with a focus on regional center vendor rates and also on the regional center operations formula that we use to fund the regional centers, also known as the core staffing formula. I'm going to talk about a couple of pressures on funding, one of them being the new federal home and community-based services waiver regulations and the developmental center closure plans. And then I'll conclude by talking a little bit about the developmental services task force. So if you will turn to page 2 of the handout, the community services program, community-based services are provided through 21 regional center organizations. They assess the eligibility through an interdisciplinary team of people who are seeking services, and they develop an individual program plans for eligible consumers. The department provides the regional centers with funding for their budget, their operations budget, in order to conduct these activities. And the department also gives the regional centers a purchase of services budget to serve an estimated 290,000 consumers in the 2015-16 fiscal year. The regional centers purchase over 100 different services from vendors on behalf of consumers. These can include housing, day programs, transportation, and support systems. And the regional centers are the payer of last resort. So the regional center purchases services if it can't refer a consumer to so-called generic services that are provided through another state-administered program, such as Medi-Cal. The majority of regional center consumers are eligible and enrolled in the Medi-Cal program. Or if they can't find services for them through other local agencies, such as counties, cities, and school districts. And now I'm going to talk briefly about the Developmental Center program. The Department of Developmental Services operates three 24-hour facilities known as developmental centers: Fairview in Orange County, Porterville Developmental Center in Tulare County, and Sonoma Developmental Center in Sonoma County, and also one smaller leased facility. Together, these facilities provide care and supervision to about 1,030 consumers in the 2015-16 year. Now, if you'll turn to page 3, I'm going to talk about the rate structure in the regional center system. How are regional center vendors compensated? Vendor rates are set in several different ways. In some cases, they're statutory guidance. Depends on the type of service that the vendor is providing. DDS sets some rates, and they use cost statements and rate schedules to set the rates. DDS sets rates, for example, for community care facilities and work activity programs. Some rates are established by Medi-Cal. The regional centers are not allowed to pay more than the maximum Medi-Cal rate for a specific service. There's also usual and customary rates, where at least 30% of a business's customers are not regional center consumers or their families. Then the regional center may pay for the service at the same rate the business regularly charges the general public. Some rates are established by the Department of Social Services. Some rates are set based on the regional center's mileage reimbursement rate. And then there are some rates set through negotiation with the regional centers and provider. If none of the methods that I just mentioned are for establishing a rate apply, then the rate is determined through the negotiation with the regional center provider. Beginning in July 2008, an upper payment limit was established for new providers of services with negotiated rates, and this limit was set at the median of all rates in place at the time for each service. Now, if you'll turn to page 5, I'm going to go over major budget solutions affecting the community services program between 2003, 2004, and 2015, 2016. Over the past decade, DDS has implemented numerous budget solutions. Here we're highlighting major solutions. We're going to focus on a subset of budget solutions affecting RC operations budget and vendor rates, generally those that yielded estimated savings of $10 million general fund or more. So first, for restrictions on vendor rates, since 2003-2004, several restrictions have been imposed on the rates paid to regional center vendors. These were implemented as a means of achieving budgetary savings. They generally fall into 3 categories: rate freezes, implementation of median rates, and provider payment reductions. The rate freezes began in 2003 for some services, including community-based day programs and in-home respite, supported living services, and transportation experienced the rate freezes in 2003-4. By 2008-9, all vendors with rates negotiated with regional centers experienced rate freezes, with some limited exceptions that you can see listed in the handout. For example, rates have been increased for some vendors. There have been increases to account for minimum wage increases. although that only includes statewide increases in the minimum wage, not those that were adopted at the local level. And then there are health and safety exemptions. Turning to page 6, the implementation of median rates began in 2008-9. So when a new vendor negotiates a rate that may not exceed the median rate for the regional center, or for the statewide median, which has been calculated, whichever is lower. There were provider payment reductions implemented beginning in 2009-10, but with full funding restored in 2013-14. Initially, those were 3% reduction. Then another 1.25% was added to bring those provider payment reductions up to 4.25%, and then those were phased out. And finally, I want to mention that the regional center operations funding has also been reduced between 2003-4 and 15-16. For example, in 2009-10, the regional center operations budget was reduced by $10.5 million general fund, and then again in 2011-12 by $14.1 million general fund. If you'll turn to page 7, I'm going to talk about home and community-based services waiver regulations. The Department of Developmental Services budget plan assumes the state will draw down more than $1.4 billion in federal funds under the home and community-based services waiver. This is a key source of funding for regional center programs. And the federal government recently published new regulations. That was early in 2014. That enhance the quality of the home and community-based services and provide additional protections to individuals receiving these services. California is embarking on a multi-year process to implement the specific requirements of the new regulations. We must come into full compliance with the regulations by March 2019. The handout describes the way that the new rules amend the home and community-based services. They're designed to improve the quality of services provided to individuals receiving home and community-based services. And then if you'll turn to page 9, developmental center closure is, in addition to the home and community-based services waiver regulation change, is another potential cost driver or something that would drive need to look at the rates that are paid to regional center vendors. The governor proposes developmental center closures. At the May revision, the administration proposed to close Sonoma and Fairview developmental centers and phase out the general treatment area at Porterville Developmental Center. In response, the legislature took several actions, including modification of the administration's proposed trailer bill in order to ensure legislative oversight over the closure process. The D.C. closure process will require development of new community resources. The legislature approved $46.7 million general fund to begin developing these resources. Some resources have actually been in development prior to that under the general policy of not allowing people to be placed in a developmental center unless they're in a crisis and deflecting them into community placements whenever possible. So rate setting will be part of the process of establishing the resources in the community that are needed to move people out of developmental centers and into the community. And generally, people in developmental centers have high acuity needs. They may have very complex medical needs or other needs. And so when you're developing those community resources, it's a very complex process to make sure that everything they need has been developed and is in place before you move them out of a developmental center and into the community. And finally, if you look at page 10, the Secretary of California Health and Human Services Agency has convened a developmental services task force. And two of the work groups that are meeting, one of them is examining regional center vendor rates, and they are meeting to discuss reform of regional center vendor rates and to develop recommendations on how to structure the rates. Additionally, a work group is meeting to discuss the reform of regional center funding formula, the core staffing formula that we use to fund regional center operations. The recommendations from the work group could inform long-term reforms in both the core staffing formula and how we pay vendors and set their rates. They may have recommendations late in 2015 or early in 2016 that could be considered during the development of the 2016-17 budget plan. So that concludes my overview of the Community Services Program, and I'll be here to answer any questions that you may have.
Okay, we'll go to our next set of witnesses, and then once all the presenters in the panel have testified, we can entertain any questions from the committee. I do want to remind our witnesses that we have you scheduled for 10 minutes, and when you get to 9, I'm going to let you know, and hopefully you can wrap up before 10. Thank you again for being here. Please proceed.
All right. Thank you, Mr. Chair, members. Mike Wilkening, Undersecretary of Health and Human Services for California. Just going to help to frame the special session real quickly up front, and then I'll turn it over to Santi Rogers, the Director of DDS, for some brief opening comments. So as was mentioned in the remarks from members, the federal government will not reauthorize the managed care organization tax as it currently exists. We're going to talk a little bit further down in the agenda about the managed care organization tax and how that's structured and what our options are there. But that is one of the things that's driving this. Is it's a $1.1 billion fund source that's been a stable source of funding for health care since 2005. We also need a stable funding source for restoration of the 7% reduction in IHSS hours. The general fund's covering that on a one-time basis in the current Budget Act, but we need to find a stable ongoing source. Together, that's a $1.3 billion pressure on the state's finances. So we need to get $1.3 billion in revenue just to maintain what we currently have. So the governor called the special session to enact a permanent sustainable funding, either from a new MCO tax and or other alternative revenue sources, both to replace the existing MCO, to restore the 7% reduction, and then also to provide any additional rate increases for providers of Medi-Cal and developmental disability services. At the end of the special session, whatever expenditures we have to have revenue that matches up to that. So that'll be a priority as we go through special session. And then for Medi-Cal rate increases, we want mechanisms to ensure that the additional resources result in expanded access to services. And for DDS, we want to make sure that we have increased oversight and effective management of the services that are provided through the regional center system. We have here today Santi Rogers, the Director of DDS, John Doyle, the Chief Deputy, and Nancy Bargeman, the Deputy Director for the regional center system. So with that, I'll turn it over to Santi for some brief opening remarks.
Good morning, members. It's a pleasure. I'm Santi Rogers. I'm Director of Developmental Services. I have a raspy voice. It might be a recessive gene of my Italian heritage, but I hope you take that as a compliment to all of our Italians. The significant part I want to share with you real quickly is a snapshot based on the intent of this committee to look at some historical information so you have a better feel for the 290,000 approximate number of people we currently serve in our 58 counties through the 21 regional centers. I think it's important. About 15 and a half months ago, I was the director of San Andreas Regional Center that serves Santa Clara, Monterey, Santa Cruz, and San Benito County. Mr. Stone knows that. I thought I used to live in Aptos, but it's been a long time since I've been home. The serious part is the same reflection on the very diverse population we have on this unprecedented piece of civil rights legislation that many people who know me, Assemblymember Stone knows that I was going to do this. This is the Lanterman Developmental Disability Services Act. For your information, based on what we were asked to share with you, and those of you who already know this, that this may be redundant, but it's one-of-a-kind piece of civil rights following the civil rights issues that occurred in the United States in the early 50s and 60s. It provides a very specific promise to anyone who qualifies under this act for a comprehensive life plan. They use terminology, and I try not to do that with you and any of your staff, abbreviations, but you'll hear terms like individual education plan in education. As a retired special educator, I understood that quite well and preceded it in my career before we even had individual education plans. And in this law, we created the individual program plan. The best way for you, I would hope, and you would embrace like I do, the individual program plan is really a life plan. From the inception of eligibility through the whole course of that individual's life. The regional center system's mission, the majority of the mission workers are social workers, are to make sure that a fact occurs. Think about that. And it is the cost of doing that and the updates as necessary for in the public policy, both at the state and federal level, is and requires great maintenance of effort. It's a one-of-a-kind act. This act, when it really was created, I started working in 1968, 69. I hope you don't think of me as being too old, but I do enjoy my AARP discounts. The serious part is that you get to meet a whole course of clientele and individuals during continuous employment, and many of it happened right in here, right in front of that gentleman who was on the wall. And we were in these rooms talking about that we needed not to leave anybody behind. We had 13,900 individuals living in our state hospitals, and many of them were children. It's before there was ever a right to education for people with special needs, and all of that law would follow later. That is important background to put in some kind of context as we look at this law, continue to evaluate it, and then how do we provide sufficient funding for the fastest growing group within the eligible group, persons with autism, and challenges accordingly. That group is growing at a phenomenal rate, and we're reaching out through all 58 counties through these 21 regional centers, addressing those issues as well as others eligible under the law. It is a huge challenge. It's a huge challenge for 9.5 minutes to explain it to you. But at the same time, I think it's really outlined clearly in our practices and what we'll be bringing forward that the LAO did an excellent job of summarizing compelling issues. I really want to thank your staff for the great summary they did on a very complicated issue like the Lanterman Act, like the regional center system. It's the only system like it, and as a result deserves very close scrutiny. As a past regional center director, like I spoke to you about, prior to being a director of 4 state developmental centers, it was always our mission guided by this act. And as a result, we have more people living in the community now than ever before in the history of California service because of this act. And I look forward to any questions you have as we move forward. Thank you.
Thank you. All right, great. Any comments or questions from members of the committee? Assemblymember Thurman.
Thank you, Mr. Chairman. Thank you all for the presentation. I wanted to ask 2 questions to kind of help set the stage even greater for the need of urgency to increase the rate for both regional center agencies and the community-based agencies that provide the direct services every day, the day programs or transportation and things of that nature. Mr. Rogers, if you could, we heard a little bit from Mr. Martin, who laid out that we draw down a lot of federal money to provide the services that we do, but my understanding is that some of that money we use to provide smaller caseload ratios. So that each regional center case manager can work with a smaller group of folks, getting them their services. But because we just don't have enough money, we're not able to maintain our caseload ratio requirements to the federal government. Technically, our money could be at risk if we don't find ways and more revenue to help keep those caseload ratios smaller. Are we not facing a situation where some of our federal dollars could be at risk if we're not able to do just that?
Yes, I'll give you a really quick comment, and then ask Nancy Bargement to add to it. First thing is we've had challenges to the Centers of Medicaid and Medicare Services relative to caseload ratios. The fiscal challenges as a regional center director 15 months ago were as real as they are today. The difficulties of fast-growing caseloads and the allocations that we were receiving relative to it is a gap, as you factually stated a few moments ago. We still have that gap. We still are in a situation that produces challenges of getting smaller caseloads because, as a past regional center experience, like I think you've had, and as I have had, the caseload of the service coordinators is the bedrock of what we do, providing services to our individuals. Each of those case managers originally our caseloads have increased over the last 10 years remarkably, and we've had challenges living within our budgets tried to reduce the caseload. So it is still a clear and present challenge for us.
So a rate increase certainly helps with additional resources to help offset some of the cost needs to manage the caseload sizes?
Yes, it would, and if it is used administratively in very targeted areas of our service.
The other question I was going to ask is about the actual community-based providers, and I know that many of them have struggled to continue to provide services because of the decade of cuts that Mr. Martin described, and it struck me, these services, as you held up the Lanterman guide, it struck me these services are in fact an entitlement, are they not? We are required to provide them. If we allow any more of our service providers to close, are we not in fact failing to meet that entitlement because there won't be available services for those who need them?
Yes, it is an entitlement in the individual plan and what is authorized in the individual plan, and we do have a challenge of meeting each of those plans.
Clearly, there's urgency for getting a rate increase for both regional center operations and for the community-based organizations, but it struck me in your presentations that there's even more urgency to get to a rate increase so that we can meet this entitlement of providing the direct services that are at risk as our community-based providers close, as well as to help us with our caseload ratios.
I believe that we're sitting here in this special session to look at those very specific issues.
Yes. Thank you for helping us add some context to the level of urgency for getting to a rate increase. Thank you.
You're welcome. You're welcome.